heart team considering a patient for recharge, how would you determine equipoise for a patient?
So that's a great question. Normally, the state of equipoise exists when you're uncertain which therapy is better for a patient, in this case, PCI versus CABG. And interventional cardiologists and cardiac surgeons can hear about a patient, can sit down together or separately and look at a film. And we can almost always come up with a scenario where we think this patient's probably a little bit better for PCI, this one's a little bit better for CABG. But that's based on all the information that we've accrued over the last 20 years of randomized trials of PCI versus CABG that have principally enrolled white men. Those trials have enrolled maybe 22% women and almost no Black or Hispanic patients. So we really don't have data to guide revascularization decisions in women and underrepresented minority patients. And this is really very important because what we know about those three groups is that they do worse with both PCI and CABG compared to men and compared to white and non-Hispanic patients. So it's very important for us to determine what the best outcome is for those patients. So what we're asking you to do when considering the equipoise question is set the clock back about 20 years before any of those randomized trials. And first ask yourself, can the interventionalist safely revascularize all or most of the jeopardized myocardium and believe that it's done in a way that they will likely improve the outcomes for the patients, either survival or quality of life? And similarly, does the cardiac surgeon believe that he or she can safely revascularize the myocardium and improve the patient's outcomes? If that's the situation, then in most cases, there is equipoise. So for example, in this trial, a patient with an 80% focal mid-LAD lesion and an 80% circumflex marginal branch lesion that normally we would do PCI on all day long is a perfect patient for recharge because a lima to the LAD may have a particular implications in women, Black, and Hispanic patients, given differences in biology, differences in priorities, differences in social constructs, etc. Similarly, a patient with a syntax score of 35 or 40 with severe triple vessel disease is a patient who would be very good for recharge if the interventionalist, as well as the surgeon, of course, believes that they can safely revascularize most or all of the jeopardized myocardium. Because we just don't have outcomes data in high syntax score patients who are women, Black, or Hispanic. Now, there's always going to be a bridge too far, one way or the other. So you might take a patient with an 80% 2.5 millimeter diagonal branch lesion and an 80% posterolateral branch lesion. No one is going to operate on that patient. That patient should be considered a screen failure, entered into the screen failure registry, and have PCI, even though they technically do have multivessel disease. Similarly, you might have a patient with a syntax score of 55 with two awful looking chronic total occlusions that the interventional cardiologist does not believe that he or she will be likely to be able to get open or keep open. That patient, if the patient's able to have surgery, should be entered again as a screen failure patient and undergo bypass surgery. But we really do believe that somewhere between 85 to 90% of patients in this trial who have multivessel left main disease and are either women, Black, or Hispanic should be eligible and appropriate and meet the definition of equipoise to be able to be randomized in recharge, given that we really do have relatively few exclusion criteria. Mario, would you like to add anything?
Yes, thank you, Greg. So I think I agree with everything you said. I think it's really important that the physician keep in mind that, as you say, the general paradigm that we use to decide who get PCI and CABG only apply to white men and not to the patient population that we are targeting in recharge. So they really need to cast a broad net and enroll patients across the spectrum of complexity and also clinical characteristic. I also want to make two quick points that are questions that generally come up from participating sites, so maybe they can be helpful to know. First of all, remember that we are testing interventions that are standard of care. So while the local PI take academic responsibility and ownership of the trial at site. Everybody who was privileged to perform the intervention can perform the revascularization procedure in this trial. Not only the PI, not only those who are listed in the IRB, unless this is a local rule, but from a trial perspective, the procedure can be performed by everybody. So I think that helps in terms of the logistics. And another question we often get is what happens if the number of treated vessel is different based on treatment allocation. And this is mostly because in the current era, PCI decisions are often based on functional evaluation, FFR, IFR, or a functional evaluation method, whereas the surgical revascularization decisions are mostly based on anatomy. So there can be a vessel with a moderate 60 to 70% stenosis that may be FFR negative and so not to be treated by PCI, and instead, because of the anatomic severity of the stenosis, that vessel is grafted if patient is randomized to surgery. This is totally okay. This is something that is allowed in the trial because it's part of the different mechanism, quite frankly, of the two interventions. So I think this is also important to clarify.